of the updates, some of the updates in the physician fee schedule. I'm also going to briefly mention a few proposals in the quality payment program as well as the hospital outpatient prospective payment system, just as they relate to cancer care. So again, this will not be comprehensive of everything in the final rules, but it is just an overview and a highlight of some of the more pertinent things. If you have questions on other topics that I did not address, feel free to address those in the chat, and I'm happy to try to answer them at the end of this presentation. All right, so to get started, we'll start with the 2025 physician fee schedule final rule. Keep in mind, all of the provisions that we discuss in this next section will be in effect beginning on January 1st of 2025, so in just a few weeks. So the conversion factor. For next year, the conversion factor will go down by 2.83%. This is essentially as CMS had also proposed it in the proposed rule. There's not a lot of change here, or no change actually. The conversion factor will go from $33.29 in 2024 to $32.35 in 2025. This is a reduction of just shy of $1. So what does that look like across specialties? So medical oncology, we expect, or we estimate that across the board as a specialty as a whole, we'll see a 4% decrease in reimbursement in 2025. Radiation oncology, this is a 3.25% decrease, and then gynecologic oncology, just over 3.5%. The reason for these reductions are, first of all, the reduced conversion factor, that 2.83% reduction. There's also the expiration of some of the geographic practice indices, those work floors in some states. Those are set to expire at the end of this year. That is factored into our estimated impact, as well as just shifts within the fee schedule itself. Because it is a budget neutral system, when some services receive an increase in payment, others receive a decrease in order to offset that and maintain neutrality within the whole system. Generally speaking, if you look at the medical oncology codes that physicians primarily bill, there is quite a decrease in those codes, which is also driving this decrease in 2025. So if you look back from 2019 to 2025, so this is just before the pandemic until next year, the conversion factor has fallen about 10% from $36 to just over $32. The conversion factor has fallen about 10% in the last 6 years. If you look at just a chemo administration code, so 96413, this is your basic low level or first, that first initial hour of chemotherapy. This code has also decreased by 16% in the last 6 years. So while inflation continues to rise and while practice expenses continue to rise, while the cost of hiring staff and labor continues to rise, we are seeing a decrease in Medicare payments to physicians and practices that is just not sustainable. I highly encourage all of you right now to take out your phones and to scan this QR code. What this will do is to take you directly to our ASCO Act Network site. And this is a very simple way for you to contact your lawmakers. You scan this code, you enter in a little bit of information, your name, where you live, and you are able to send pre-drafted, customizable letters to your representatives asking them to address these unsustainable cuts in Medicare physician reimbursement. The first thing right now, what we're doing is we really want Congress to just address the cut most immediately for 2025 to prevent the full 2.8% reduction for next year. There is also long-term advocacy efforts on the Hill to get Congress to address this more permanently. Some of the things that we need Congress to address are these inflationary updates. Right now, there is no inflationary update built into the physician fee schedule, which is really problematic when you have got increasing prices. The other thing is to eliminate the budget neutrality adjustment so that when the cost of providing one service goes up, that doesn't mean a decrease on the other side to keep neutral payments within the system. The other thing we really would like to address is to make meaningful changes to the merit-based incentive payment system. This is MIPS. This is part of the quality payment program. This unfairly penalizes especially rural practitioners, solo practitioners, and small practices. They bear the brunt of the penalties in this program, and that is also not sustainable. And then also we would like CMS to incentivize the transition to value-based care. So again, just a plug for our app network. If you feel like you need to do something, again, highly encourage you to look at this. It takes just a matter of minutes. And the impact that you can have goes a long way. Okay, so let's get into the meat of some of the things that are actually happening as far as policy-related items go for next year. The first thing that I think is kind of at top of mind for most everyone right now is telehealth. So there were a lot of flexibilities that were put in place during the public health emergency that essentially expanded telehealth to all Medicare patients, regardless of where they live, regardless of where they choose to receive telehealth. They could even do it at home. So beginning on January 1st of 2025, so in just a few weeks, all of those flexibilities will no longer be in place, and we will go back to the way telehealth was implemented before COVID-19. This means that patients will need to travel to an originating site facility. So this is something like a federally qualified health center, a critical access hospital, another clinic or hospital, something where they're not actually seeing their physician, but they are accessing their physician through telehealth, going to this site. We call them originating sites. The other thing is that physicians will need to be located in a rural area to receive telehealth. The expanded flexibilities, which let any Medicare beneficiary, even those living in urban areas, that is no longer in place beginning January 1st. This is, of course, unless Congress doesn't act. So there's what we need to happen in the next 6 weeks is we need for Congress to extend these flexibilities. Right now, nothing has been done. I think it's highly likely that they will extend the flexibilities. However, we don't know for how long, and we don't know when these flexibilities may be extended. Kind of at first we thought it would be a 2-year extension, then we thought it would be a 1-year extension, and then the last I heard it was actually only a 3-month extension. So we're keeping an eye on this. There's also an ASCO Act Network alert for you to contact your representatives to urge them to continue these flexibilities into 2025. And I'll put the slide up for that at the end. And I think Allison actually put it in the chat also. So that's just the big picture, that unless Congress does something, pre-COVID telehealth rules will be back in effect beginning on January 1st of 2025. Okay. So there are some things that Congress can address. And in the final rule, they did make a few changes. The first one is audio-only services. So they will permanently allow beneficiaries and patients to receive telehealth by audio only, meaning they don't have to have the visual component. It could just be over the phone. This would apply to any service that's on the Medicare telehealth services list. But the caveat here is that they need to be at home in order for them to have audio only. The only way they can be at home is if Congress extends those Medicare telehealth flexibilities. So this one, there's a little bit of a catch-22 there. That does not apply to behavioral health services. For behavioral health, you can continue to receive audio only, and you can do those at home. Practitioner home address. This is something we heard a lot about from our members. CMS had released guidance, I think a year or two ago, stating that any Medicare practitioner that offers telehealth, and they do so at home, would need to report their home address on Medicare enrollment forms. We received a lot of concerns from our members that they were not comfortable putting their home address on Medicare enrollment forms for privacy reasons, as well as just the hassle of having to update the forms. CMS heard us, and they are not they're not going to require this through the end of 25. So for the foreseeable future, for the next year, you will not have to report your home address. And then the other thing that they were able to do was to continue the public health emergency flexibility, allowing direct supervision to be done through audiovisual technology through the end of 2025. Again, this is a flexibility that has been in place during the public health emergency and into 2024. They will continue this for one more year through 2025. They've also permanently adopted audiovisual direct supervision in two different instances. The first one is for code 99211. This is for the outpatient E&M, that low-level office or outpatient E&M. And then also for any code that has a PC TC indicator of 5. 96413 would be an example of a service with a PC-TC indicator of 5. Basically, the reasoning for this is because these are services that are primarily done by auxiliary personnel, and they believe that direct supervision is fine and safe to be done through audiovisual technology. There are some updates to the Medicare telehealth services list, though not a lot. During the public health emergency, CMS added quite a few services to the list on a temporary basis just during the public health emergency. Those are also still there as those flexibilities are in place. And CMS did make a few updates. The first one is care management codes. They are not adding those to the telehealth list, neither on a provisional nor a permanent basis. They continue to reiterate that these are services that are done face-to-face between a physician and their patient. The next one is radiation treatment management. This one, stakeholders had actually requested that CMS remove these codes from the telehealth services list. However, CMS declined to do so, and they will keep them on the as a telehealth service provisionally for the next year. If you're interested to see the full list, that's on table 11 in the final rule. I won't go through all of them. Just another thing to note that CMS has acknowledged that there are a fair amount of codes on the provisional list, and they do expect to do a full review of all of those services. However, they did not offer any clarity on how they would do it or any timeline on when they would do it. But we will expect that within the next, I would imagine, a few years, that they're going to go through and reevaluate all of the codes on the telehealth services list. A couple of other things as they relate to telehealth. CMS is adopting new code 98016. This is a virtual check-in code. This replaces a CMS only code of G2012. What this means is that now private payers are also able to bill, as well as Medicare. There's a work RVU of 0.3. This is just a check-in code to see whether or not a patient needs to come into the office to be seen or not. It is not related to an E&M. It is just it's just a quick check-in to see if they need to come in or to, email a quick question or something. The second thing is the CPT editorial panel, which is the AMA, and they are the ones responsible for maintaining and updating the code set. Last year, the CPT editorial panel finalized 16 new telehealth codes. This is 98000 through 98016. They are broken into 4 sections. Some for new patients, established patients, audio only, and then also audio visual. Essentially, these are evaluation and management codes that are done only through telehealth. CMS, despite the AMA adopting these services, the CMS has decided they will not reimburse for these codes. They are given a status indicator of I, which means that they are inactive in the fee schedule. The reasoning behind this is that CMS says that the existing office and outpatient evaluation and in management services that are currently on the telehealth services list are essentially the same thing, and that by adopting those new codes, they would be duplicative. So if you're billing Medicare patients, you're going to continue to just bill your office and outpatient E&M. If they are new or established audiovisual or audio only, you're just going to use those new, sorry, not the new ones, but the already existing office and outpatient E&M. One other note on E&M. So last year in the final rule, CMS created a new G code for complexity. This is to capture the relationship between a patient and a physician, an ongoing relationship between the two, for which the individual may have a complex care need. This is code G2211. So this code can be added on to any office and outpatient E&M for new or established patients. So 99202 through 99215. And again, like I said, this is really to capture the relationship between the two. I think CMS anticipates high volumes of these codes. And we have a lot of resources on our website for you to check out about when it is and is not appropriate to bill this code, but it's definitely worth looking at. One thing to note is that you cannot bill the complex care add-on code, the G2211. You cannot bill this with a modifier 25. So that would be like a drug admin code and an E&M on the same day. That is still in place. Beginning in 2025, CMS is expanding the use of G2211. So everything I just talked about stays the same. That is all still there. They are just adding on and one additional time that a physician can bill the base E&M code, so like 99202, with an annual wellness visit or another preventive service, which requires a modifier 25, and then also the G2211. So they're just adding on. You can use the E&M, an annual wellness visit, and G2211 all in one visit. All right, moving on. A few more coding updates. So our coding and billing team has been hard at work this last year, getting updated coding for CAR-T services that are provided in the non-facility and the facility setting, so an outpatient or clinic. CMS, or the CPT and Reddit editorial panel and the RUC adopted 4 new services to capture these codes. They are 38225, which is for the harvesting of the T cells. 38226, which is the preparation of the cells. 38227, which is receipt and preparation of the CAR T cells. And then finally 38229, which is the actual administration. As you can see from this chart, there are work RVUs associated with all four codes. There's only a non-facility PE RVU, and then there are facility PE RVUs for all the codes. The thing to note, however, is that for codes 38225, 6, and 7, these first three, CMS has assigned them a status indicator of B, meaning that they are bundled. So these three services are not separately reimbursed. Only this final code will be reimbursed under the fee schedule. This is 38229, the actual administration of the cells. So although there are PE and RVUs in the file, just note that that is a status indicator of B, meaning that they are bundled and that they will not be separately reimbursed. Health equity. So last year, in the final rule, CMS adopted new coding, Medicare only coding for principal illness navigation, community health integration, and also social determinants of health risk assessments. These are CMS only codes. CMS is really trying to promote the use of addressing social determinants of health and other risk factors, as they are very important to clinical care. They did not make any changes to the codes for this year. They are the same as they were last year. But I think CMS is kind of concerned that there is not a great adoption of these codes. So they're really trying to promote their use. However, they're finding that clinicians and practices are not billing them as often as they were expecting, as often as CMS was expecting. Just wanted to let you know that if you have any if you are billing them, I'd be curious to hear from you. If you're not billing them, but are interested in billing them, I'd be curious to hear from you. They're continuing to work on these and they're continuing to update them because CMS really does believe that they are, important parts of cancer care. So we submitted comments on this. Again, CMS didn't do anything. But some of the concerns that we've heard from our members is the administrative burden with billing, particularly the principal illness navigation, and the lack of integration into the electronic health record. The other thing is that there's concerns and questions about whether or not billing navigation would trigger a cost measure in MIPS. And then also the issue of cost sharing. So when you bill the CMS only codes, by law, sorry, not CMS, but by law, physicians have to charge cost sharing. That is written into law. There's no way around it, which means that if you offer navigation, your patients are also responsible for their share of the service. And I think that physicians and practices are finding this hard to do because you've identified someone with, with some sort of risk factor or social determinants of health related risk or need, and then having to charge them and create more financial burden on top of that is extremely difficult. So although CMS cannot address it, it is something that we are also working on raising awareness of and just, acknowledging that that is a burden and a barrier to billing these codes. Just a few other things in the fee schedule. CMS is updating their coverage as it relates to colorectal cancer screening. They are removing coverage of a barium enema. This no longer aligns with guidelines or the United Services United States Preventive Services Task Force. It does not align with their guidelines. This is kind of an out-of-date screening tool. So CMS will no longer cover this. And instead, they will cover the computed tomography colonography, which is more commonly used and also much more in line with guidelines. CMS will also cover a follow-on colonoscopy, a screening colonoscopy, after a patient takes a Medicare-covered blood-based biomarker test. So if they do this blood test and it comes back as being positive, Medicare will cover that follow-on colonoscopy as a preventive service, not a diagnostic one, so there would be no cost sharing. Last year, or maybe it was the year before, CMS finalized something similar for those that take a home-based stool test. So that's still in effect. If you take a home-based stool test and it comes back positive, your patient would also qualify for a screening colonoscopy without cost sharing. CMS is continuing to look at dental services. They did not make any changes this year, but just a reminder that cancer patients are eligible for Medicare-covered dental services if they are receiving chemotherapy or CAR T, or if they are receiving bone-modifying agents, especially the ones it causes osteonecrosis of the jaw. And then finally, those that have head and neck cancers. Medicare will cover dental services for those individuals. And then CMS is continuing to look at other preventative services, such as offering hepatitis B vaccines without a physician's order. And then they will also begin covering PrEP. And then just a few notes on the quality payment program, especially as it does relate to payment. The first one is, I'll just back up and say there's not a ton of stuff in the quality payment rule. Not a lot. I mean, there's some very technical details that they changed, but not a lot that's like really big. So this slide will be quick. The first one is the MIPS performance threshold. They're maintaining that at 75 for this year or for 2025. CMS estimates that 15% of all MIPS eligible clinicians will receive a penalty in 25 performance year. You'll see, if you think back to that first slide where we talked about the problems within MIPS and how some providers are feeling the penalties more acutely than others, these second three bullets kind of show this. Solo practitioners, 46% of them who are reporting MIPS will see penalties in 2025, and then same thing, small practices, 21%. So this is just to illustrate to you why we need MIPS reform, and how it's not the same across different practice types. Within advanced APMs, there is no incentive payment for 2025. Congress had allotted, I think it was 1.88% in 2024. That expires at the end of this year. So there is no performance payment, or no incentive payment for performance year 25. And there's also no modifications to how CMS is determining qualifying participant status. They did, however, mention that they may address that in future rulemaking. We will, of course, be very engaged with the agency as they continue to look at that, because that makes a big difference. MIPS value pathways. This is, so MIPS value pathways, this is a reporting option that is available to all MIPS eligible clinicians instead of MIPS. It is related to a specialty or a medical condition, and you only have a select set of measures from which to report. So right now there's, I think, shy of 200 quality measures in traditional MIPS. Well, in MVPs, you would be limited to like 15 or 20, depending on the MVP that you're reporting. Then there's still, of course, promoting interoperability, cost, and improvement activities also, but they're much more limited compared to what you have in in traditional MIPS. So currently, there are 21 MVPs available. The Advancing Cancer Care MVP is one of them. MVPs are currently voluntary. You can report this instead of MIPS if you choose. However, despite the fact that there are only 21 MVPs available, and if my memory is correct, there's, I don't know, 60 or 80 specialties, countless medical conditions within the CMS program. And if they're trying to get everyone to report MVPs and they only have 21, there's a long way for them to go to establish an MVP that would capture everyone that offers Medicare services. So currently they're voluntary, but CMS is signaling 2029 as a date to move to MVPs and then sunset traditional MIPS. We are working very closely on the agency with this. We do not believe that they are in a position to do this yet. There's a lot of work that needs to be done. Obviously, they only have 20 MVPs and there's, 60 or 80 specialties. They haven't been up and running that long. There needs to be more testing. So just to keep that in mind, that they are moving toward MVPs. However, nothing has been finalized. Nothing has been decided. This is just to make you aware of what's happening. Again, one more time, here's a link to our ASCO ACT network. This QR code right here will take you to the ASCO ACT network page. We have alerts right now for telehealth, as we discussed. Also for Medicare physician payment, as we discussed earlier on, drug shortages, cancer research funding, and prior authorization. I highly encourage all of you to go to this to read through what we have. It is such a quick and easy way to contact your lawmakers. And then before we move to questions, just a couple of quick notes on the hospital outpatient prospective payment system. Like we saw in the fee schedule, there are codes for CAR-T that will be available for use beginning in 2025. Similar to the fee schedule, the first three codes, 38225, 6, and 7, those are bundled. They will not be separately paid. Only that final administration code of 38228 will be reimbursed under the outpatient payment system. So same thing as in the fee schedule there. One thing to note on how the therapy itself is reimbursed, CMS will separately pay for cell and gene therapies. So they are not going to be packaged into the CAPC, but they will be separately reimbursed. That's ASP, or average sales price, plus 6%. And that is for 2025. And as far as we can tell, all subsequent years. When CMS proposed this, they initially thought they would just do it for 2025. However, as a result of stakeholder feedback, including ASCO's, they are doing this for 25 and all subsequent years. Prior authorization. A few years ago, CMS introduced prior authorization into fee-for-service, where it had typically does not occur. This year in the proposed rule, they are not adding any services, which is fantastic. There's, I think, only a list of about 5 or 10 services that require prior auth, none of which are oncology related. But because prior authorization is such a burden for physicians, we always keep an eye on this. And just a quick note, in the fee schedule, or in the outpatient, they are adjusting the non-urgent request timeframes. They are shortening them from 10 days down to 7. This is 7 days, not working days. They do not address urgent requests. However, they may do so in future rulemaking. This is just for your awareness. Again, this does not directly relate to oncology services, and we don't want it to. So we're keeping an eye on this. Just last few things, payments to hospitals will increase by 2.9% next year. This is in direct opposition to the 2.8% decrease to physicians in 2025. The AMA has a wonderful graph where you can see all the payment systems in this nice, increasing line to hospitals and other facilities while physician payment goes down. Just to keep this in mind. CMS is implementing laws which require children under the age of 19 who are receiving Medicaid to have continuous eligibility for 12 months. That means that they do not have to go through that re-enrollment process or that recertification process every month. Once they enroll, they are enrolled for a full 12 months. The cancer screening updates, the colorectal cancer screening updates, those are the same as it was in the fee schedule. The outpatient prospective payment system will cover them the same way. So removing the barium edema, adding the CT scan, and then the same thing with those home-based tests. And then just a few notes, there are no proposals or changes. Nothing was finalized in terms of drug shortages or 340B. Though we are, of course, watching those in other areas. And that is everything I have to keep up to date. In addition to the ASCO Act Network, our policy and advocacy updates can be found here at ASCO in Action. All of our coding and billing resources, if you need information on G2211, navigation, CAR-T, anything, care management, we have it all. It's up on the ASCO's Coding and Reimbursement Resources website, which is right there. And I will stop there and happy to answer any questions if anyone has any.
I do not see any questions in the chat right now, but I'll give everybody another minute to see if they want to ask a question. As we mentioned before, and I'll put it in the chat, you can also send post-webinar questions to practice@asco.org, and a member of ASCO staff will be happy to help.
I would just urge you all to stay in touch with our ASCO in Action website. We will keep you posted on actions that Congress does in the next few weeks because there could be movement, both on a physician reimbursement fix as well as telehealth. That is probably not going to happen until closer to the end of December. We will keep everyone posted. We will send out alerts. We will update our website. But just keep in mind that those are things that we are watching very closely for, are both the conversion factor fix as well as telehealth.
Well, thank you very much, Gina. This webinar was recorded and will be posted on ASCO's website later for additional viewing. Thank you very much for attending. Have a good night.